Let's get started here. Oh boy, now I'm loud. Okay. So, welcome to our regular Thursday D-Mice Informatics Conference. I'm Aaron Cohen, an associate professor in the department, for those of you who don't know me. Some of these Thursday conferences we designate as IDL Talks, Informatics Discovery Lab Talks, and if you don't know what that is, you can look on the video the talk that I did a couple weeks ago and learn anything about you want about the IDL. But our IDL Talks, we try to, this is really loud, I hope it's not bothering anybody. We try to invite entrepreneurs, luminaries, experts in diverse fields, things you might not hear in your typical informatics conference. I should say that so today we have Dr. John Hurdle, who is both a colleague and a personal friend and a really great guy, and he's doing some interesting things in informatics that I think are a little atypical or certainly leading edge that I'm really excited to hear about. Dr. Hurdle is a professor of biomedical informatics with over 25 years experience in combined software development and informatics research. In researching his bio and CV on the web for this, he got a Bachelor's of Science in Chemistry from Colorado in 1976. I did not know this until today, but he did his MD and his MS in computer science at the same time in 1981 at Columbia and University of Colorado. I don't know too many people that are crazy enough to do that, including myself. I would be crazy enough, but I didn't. So he got a PhD in computer science from the University of Utah in 1994. He served as an NLM informatics fellow, senior informatics fellow from 2004 to 2006. And from 2006 through the present, he has been faculty at the University of Utah in biomedical informatics. His research interests include health services research at the VA, patient safety research, especially adverse drug events, and more recently in clinical natural language processing, all, of course, at the University of Utah. Several years ago, driven very much by several enthusiastic graduate students, you have to tell me about them, he was introduced to the nascent field of nutrition informatics. Today, he'll make the case that nutrition informatics holds great potential to improve health outcomes, both in personalized medicine and population health. I am really pleased to introduce Dr. John Hurdle, and I'm really interested to find out what is nutritional informatics, because it sounds very new and leading edge to me. So with that, I will give John the floor and the rest of the time. Please remember, we're recording this, we're streaming it, you know the drill, push the button if you ask a question so that people at home can hear you, and so it gets recorded so that not just the answer, but the actual question can be heard on the recording.
Thank you, Aaron. Am I coming through okay? Can you guys hear me? I feel bad for you all. I'm going to try to scoot over here as far as I can so you can see that screen at a bad angle. Elizabeth said there was going to be a small crowd. I was expecting 6 or 7. I'm delighted that this room is full. I know you came for the pizza, but I'll try to make this informatics thing interesting. And even though, despite what Aaron just read off in my bio, that all sounded very organized and planned. But as we were discussing last night at dinner, it's never organized. It's never planned. It was very organic. It just happened that I ended up in Utah, which had the oldest informatics program on the planet. Pure luck. So there's a lot of luck. So for those of you who are still students, don't overplan, but do respond to the environment as it changes around you. So that's a very long title. Let me just show you the people who work with me on this. I have a couple of graduate students, the first two there, Philip and Volley, and a postdoc. And we just hired a registered dietitian who also has an MS in statistics. And she's in our department of biomedical informatics. We work with a couple of nutritionists, our division of nutrition at the university, a marketing person who's interested in health behavior change and behavioral economics. And then we just started a collaboration with people up at Utah State University, which is our land grant institution. Now, I'll talk more about what we're doing with USU and, as we go through this. So you may be wondering, well, why is this thing about nutrition and informatics here at the IDL? Well, I looked up the IDL, and I think there are two of the sort of summary points that this talk and our work speaks to: fostering highly relevant informatics research on real-world problems. Like a lot of people in this room, I mean, we all write papers, we all try to get grants. You know, we make these incremental changes, and it does help the university because they get their money, and it helps us because we get some of that money, and we help students because they get some of that money. But as you get further in this discipline, I find that I got more and more desperate to do something that would actually affect the real world, as opposed to increase my publication count or my H-index. So I was happy to find this real-world problem. And the other is uncover commercially viable informatics opportunities. This is one of the core principles of the IDL. And as you'll see, we think that there is potential commercial application here. And please don't hesitate to ask questions. Nutrition informatics is a relatively unknown subdiscipline of our field. You're going to have questions. You have to ask them. And if you don't, I'll start picking on Dave Dorr. So to protect David, ask me now. Normally a talk like this, you give a lot of slides sort of justifying why you think what you're doing is important, but really, do I need to make the point that poor diet is a problem in this country? This is a map of incidence of diabetes, very much diet-related disease. It shows the incidence by state. In 1994, only one state, South Carolina, had an incidence of diabetes greater than 7%. Scant 18 years later, there was only 4 who had that, and everybody else was well above 7%, right? So in that relatively short period of time, the entire country flipped. And the same thing happened with obesity rates. There wasn't a single state in 1990 that had more than 15%. By 2010, there wasn't a single state that had less than 20% obesity rate in the state for adults. So it's a problem, and it's not going to go away. And it's not just adults, it's kids as well. In that, in the last 3 decades, childhood obesity has doubled. There's some evidence now that's flattening off, which is a good thing. But adolescent rates have quadrupled in that period. So we do need to find a way to get nutrition and diet into the shared decision-making process. And we think the way to do that is to come up with a number, a system, a hemoglobin A1C equivalent, a BMI equivalent, to get the discussion going. And if you look at EPIC really carefully, you'll find next to nothing on nutrition that actually supports things like clinical decision support. And that's what we're headed for with this kind of work. This is the state of the art of nutrition counseling. How many people here have heard of the food pyramid? Almost everybody. Well, the USDA threw that out, and now they're talking about what they call My Plate, which is this thing. And in essence, it's, you want to spend about a quarter of your plate on carbohydrates and a quarter on protein, a quarter on vegetables, and then other stuff like milk. That's great for a plate, but it's really hard to actualize that at the shopping center. Like, you have to take this information and make that into something you're going to buy at the grocery store, which is where we want to operate. But that really is pretty much all we can tell clinicians, unless you're a trained dietitian, how to advise people with nutrition and diet. So I'm going to jump to the very end. This is where I want to be in the next decade. And so here's the big idea. People shop at their store. They ring up their sales receipt. Behind the scenes, the store, almost every store in the country now stores and tracks the UPCs that are scanned and the barcodes on the fruits and whatnot that people buy, and put them into a database. So we want to take that data out of the grocery realm and use our tool, which we call QualMart, the Quality Measurement and Recommendation Tool Set, to recommend back to the shopper in whatever recommendation style they want. Maybe it's a text, maybe it's a coupon, maybe it's a menu, maybe it's a shopping list, maybe it's an app. My 20-year-old daughter would want an app, I'm sure. My 65-year-old sister probably wants a shopping list. But steer them into a healthier overall shopping cart and then measure if that actually affects health-related outcomes. At the same time we're doing that, we think, because we can measure this data over the long term prospectively, we can see if these households are actually taking advantage of these recommendations. So if they are, we'll know it because we'll see the signal change in the database of sales receipts, and then we can feed that back to people who are interested in keeping their customers, their clients, their patients healthier. So major medical centers that are worried about the ACO movement, wellness programs, health plans, all these different groups have a vested interest in keeping their patients and their clients healthy and happy. So I'd like to see a system where they're actually providing some cash equivalent incentive to have these households take our recommendation. So that's the big picture. That's the big personalized medicine There's not a bit of a genome in there, but it's real-world data that we think we can use to help steer people into a healthier lifestyle. Now, so we're arguing we can measure this stuff, and I'll show you how we do that in just a second, from grocery sales data. What is the state of the art? Does anybody know? Does anybody know what the state of the art in figuring out the quality of someone's diet? Exactly right. This is the 24-hour recall food diary. It's handwritten. Let me zoom in on that. So this says 7:15, 1 cup tea, 1 cup skim milk, 1.5 teaspoons of white sugar. And most people can't keep track of this, so it takes typically a dietitian to tease this information out of somebody in an interview. Some people are smart enough to actually, because it takes a lot of work and effort to remember all this stuff. Another popular tool is called the Food Frequency Questionnaire. And if you can't read that at the top, it says, over the past 12 months, how many times have you had breads or rolls as part of a sandwich, including a burger? 1 to 6 times a year? 7. So you have to think back the entire year and average out your bread consumption, and that's question number 65. So this is the state of the art. Now, the National Cancer Institute developed an automatic 24-hour tool, which is actually pretty slick. It's nice because not only does it collect the information and help you figure out what you ate, but then we'll give you a score called the Healthy Eating Index, which I'm going to talk about in just a second. This has never been validated in low-income populations, and we have a grant from the USDA to do exactly that, because it is something. I mean, it's something that's fairly inexpensive because it's online to get into people's hands. But still, you can imagine. I mean, you have a low-income family. Are you going to get them every week to sit down and do this, and how are they going to do it? So we're trying to take the pain out of things like this to make it as easy as possible for patients and for whoever your client or customer is. The Food Marketing Institute is sort of the big professional society of grocery stores. There's some 40,000 retailers that belong to it. And they recently published a big issue on food and diet and quality, and this was their main graphic. So cost and lack of motivation, major barriers to eating, confusion about what's healthy, what's not, but that's getting, we think, better. Let's unpack that just a little bit. The USDA would argue that cost is not a barrier. They have some very smart economists who spend a lot of time trying to show you that Americans can eat well even on a budget. And I'll give you a glimpse at that in just a second. So USDA is convinced that cost really isn't the factor. Lack of motivation, maybe it's because we're deniers. So studies have shown that the perception of most parents, only 10% of parents will admit in an interview or on a survey that they think their child is overweight or obese. But in fact, we know that a third of them are. So there's a mismatch here, right? People are just not fessing up to the fact that they've got a problem. So part of this lack of motivation is just really lack of understanding and maybe denial. And in terms of confusion about what to eat, they don't think it's much of an obstacle anymore, but I would argue it's just the opposite. The proliferation of apps, you can find literally hundreds, if not thousands, of diet-related apps, MyFitnessPal being one very popular one, but others as well. Trying to separate the wheat from the chaff in that very noisy app environment is non-trivial, and that's where we think Walmart can actually be of use. Aaron.
And 2 things. First thing is, where do you see time in this? Because it may not be cost or lack of motivation. It might be that I'm working 80 hours a week and I can't do what it takes. And the second is, if you could make just a comment about the changing definitions of what is a healthy diet. High fat, low fat, high carbohydrate, low carbohydrate. This is a bad fat, this is a good fat. It's just like, this has all changed a lot over the last 10 to 20 years, and it's not clear to me that it's stabilized or not.
And that's true. So speaking to your first point, sure, you want to make this as easy as possible for patients or customers or clients, absolutely. So that's one of the things we're going to argue, Aaron, is that Walmart doesn't require anybody to do anything except what they do anyway, which is to shop. And we'll show you how that works. Your second point is very well taken. So a lot of nutritional epidemiologists think the reason that obesity rates flipped in this country from under 15 to well over 20 across the country is because in the 80s and 90s, all the really sort of quote-unquote solid nutrition science was saying avoid fats And what happens is people replace the calories with carbohydrates, and packaged food along with those carbohydrates, lots of sodium and sugar. And we began to eat less meat and less fat and a lot more carbohydrate and sugar. And a lot of people think that's a prime driver for that flip for the country. So now they've actually, so the brand new dietary guidelines for Americans just came out last year in December of 2015. Every 5 years, USDA publishes sort of the current thinking. They measure what people are eating through the CDC NHANES survey. Anybody know what the NHANES survey is? You want to? Every 2 years. Exactly. So every 2 years, CDC amounts is huge. They send out literally convoys of big rigs full of DEXA scans. They do a couple days of scanning, of blood work, all kinds of physical interviews, measurements, calipers, and they do a nutritional assessment. And they do typically 8,000 to 10,000 individuals that are picked to be representative of the current distribution of gender and race in the country. And then they publish that data, and then USDA uses so NHANES is the National Health and Nutrition Examination Survey, NHANES. And they use that data to see what Americans are eating. And so then they do that for a couple of years, and then they come out with new dietary guidelines because they say, oh, we're not eating enough green vegetables, not eating enough whole fruit, based on that survey. So there's science behind this. But to Aaron's point, so now in the 2015 guidelines, they've totally de-emphasized fat. Saturated fat's still bad, but they think that meat and fat aren't the villains that they used to be. Added sugar is the big bad guy now. So now they're going to see this big push from USDA and other people to get rid of added sugar in foods and drinks, particularly sugar-sweetened beverages. So my response is, Aaron, I hope you'll see by the end of this that the way we're organizing this shopping data lets us change pretty nimbly. If the guidelines change, we don't really have to change the underlying architecture, just some definitions, and this will make more sense when I get into the meat of the models. By the way, how long do I have? Okay. Sure. And I tend to talk fast, so please stop me. If I'm not making sense, you got to throw a piece of pizza at me, preferably Hawaiian, my favorite. We do have a conceptual model. I was hoping Joan would be here. I wanted to put up a conceptual model because people who do science right start with conceptual models. This is one by Glance, which is tries to sort of create a healthy nutrition environment conceptual framework. And where we put our work, I know you can't read all this. This is a government, community nutrition organizations, consumers, information, and then the actual socio-demographic attributes of the house. We put ourselves here, the consumer nutrition environment, and over here in the perceived nutritional environment. As you'll see, all of our work is focused not on individuals, but on households. And I'll try to justify that as we move along. Okay, so how does this thing work? So you've all seen, you've all gone to the store, you scan, right, and all those little UPCs and other codes get stored away along with the little descriptor which appears on your sales receipt. It turns out we team with the largest grocery retailer in the country, the largest pure grocery retailer in the country. Walmart sells more food, but they sell more everything. But in terms of people who specialize in grocery stores, we team with the biggest chain. And you'd think, I mean, they've got to get these descriptors. This says, for example, bananas, which is fine. This says BKRYSS donut. So they have to squish these descriptive terms, which could be really useful for us, into these little tiny fragments. And we just assumed that back home in the big database, they had linked this to a full descriptor and all kinds of information about the food. But they don't. That's what they store in their central headquarters. So we had to scramble looking on the web trying to disambiguate these names. And that's a mapping question, which is probably more detailed than you want. But anyway, it complicates our life. So we take these sales data from a grocery retailer, we run it through our mapping algorithms, and at the moment we're focusing on two different models. One is based on something called the USDA food plans. I'll show you a picture of that in just a second. And in the USDA food plan world, USDA says people who are on food stamps, now called SNAP benefits, That's one budget. There's low income budget, middle income budget, high income budget. And they create 4 different food plans depending on how much money you can afford and want to spend on food. And then they look at the breakdown by gender and by age, and they come up with these tables that tell you how much to eat if you want to conform to the current dietary guidelines. And they categorize food into 29 different kinds of food categories, food groups, if you will. The Healthy Eating Index, which was created with National Cancer Institute and USDA, takes all the foods and lumps them into 12 categories and then scores them and gives you a measurement of what you should be eating in those components. So it's 2 different views, one that's oriented towards food plans and one oriented towards this Healthy Eating Index. The key here is, with the one, there are 12 different ways of categorizing food, and with the other, there's 29. Yes, ma'am. The question is, are these based on what we would think of as like a food group? You'll see some examples. I know very little actually about the logic, how they decided to break foods up into these 29 categories, for example, for the food plans. It's a little clear with the HEI because they were trying specifically to take the foods from the dietary guidelines that are based on NHANES and say, okay, we need to focus on dark leafy green vegetables, so that becomes a category. With the categories with the food plans, I have no idea how they do it. She asked a question, which means you guys can now ask questions because you got that off the book. Okay. And then once we map these UPCs to these different categories, then we can calculate a score. And if we know the past preferences that a family has expressed, if we detect, so if this is an example of what the food plan data might look like, and if this family was perfect, that would be a flat line. They'd be spending exactly the right amount of money on these 29 different categories of foods, but here they're spending too much on refined grains and too little on whole grains. So we want them to spend more on whole grains, less here. So if they do buy whole grains, maybe they like popcorn, USDA considers popcorn a whole grain, or corn, then we'd recommend, look, buy more corn, buy less Wonder Bread. Right? And we know what they like to buy based on their past expressed preferences. So that gives us some help to make recommendations. And this tells us what to recommend, what kind of recommendations to make here. So so you saw the big picture, right? We want to take those recommendations, feed them back to the family, measure to the extent to which they take the recommendations, and then incentivize them to improve. Does that make sense? Okay, so the Healthy Eating Index, what I just said, is the most widely used metric these days in most nutrition research. Has a very handy property. It applies to an individual. You can apply it to a household. You can apply it to an entire store. I'll show you that in a few slides down the stream here. You can apply it to a county. Some researchers actually from USDA published the Healthy Eating Index of the entire food stream of the whole country. People have published the Healthy Eating Index of Taco Bell, for example. So it's very, you can imagine, it didn't do terribly well. But it's a handy metric because it's very flexible in how it can be applied. And what it does, you can ignore the stuff on the right for a second. It breaks it. These are the 12 components. This is the 2010. Now that the 2015 dietary guidelines have come out, they're going to rethink this to get the ones that help us understand those new guidelines. Total vegetables, greens and beans, total fruit, whole grains, dairy, total protein. These are the categories into which they score. And they score 0 to 5 for ones that are somewhat important, ones that are really important, like dairy and whole grains. They score from 0 to 10. And these are negative scores. So the higher the score you get here, the less of these things you're eating. These are the bad things. These are solid fats, added sugar, and alcohol. So they're considered to be things we should moderate as opposed to things that we should try to buy more of. That's what the Healthy Eating Index looks like. Ignore the thing on the right. I'll mention that just a second. So we can map UPCs into these categories, and then using a very clever algorithm, figure out the HEI, the score for each component. And just to give you an example, here's the score, in this case for an entire household's 12-month shopping window in a store in an upper middle class neighborhood in Salt Lake City called the Avenues. And so the longer the bar is and the greener it is, the higher the score. I'm not saying that this is the best way to display the score, but it does get the point across. The smaller, the grayer, middle. Smaller still, redder, bad. So this particular household for that year did pretty well with total vegetables and refined grains. Not so well with seafood and protein. A little bit okay with the whole grains. Compare that household to one we picked at random from a city called, I do it injustice, a town we call Moab, which is in southern Utah. It's a tourist town, very seasonal. People come in, they go hiking, and they leave. Did great on total protein, bought their meat, but they weren't eating whole fruits, grains. And that's kind of what you'd expect, right? There's a certain amount of face validity there because the nature of this town is just such that people come and go, and the whole town's economy is boom and bust. Great in the summer, and in the winter it's dead as a doornail. So the shopping quality there is, by and large, lower. Yes, ma'am. Really insightful questions. The question was, does the food map, do foods map directly into one-to-one? So if you give me a UPC, I can tell you which code it should map to. In the case of the Healthy Eating Index, it maps to, I'll tell you what, let me hold that question until I show you how the Healthy Eating Index model works, and then you'll see there's actually an intermediate representation where we distribute. The answer is, we do map it one-to-one to get another kind of category, and then in that category can distribute like the whole grain part to this thing and the vegetables to another group. And I think that will make more sense, and you'll see it in a second. Yes, ma'am.
I have a quick question on how you're defining household. Like, for example, the food in Moab, is that people who live in Moab, or does that include purchases by people who are in Moab for a biking weekend?
Right. So the question was, how do we define household in this context? This is the only way we have of linking a given household to their shopping history is through their loyalty card. This particular grocery chain uses a loyalty card system, and they use it throughout the country. They claim that 96% of their shoppers use their loyalty card most of the time. And that's important to them because that's how they get customers to come back to their store. So in Utah, I get a reduction in the price of gasoline the more I shop at my Smith store. So they've got every incentive to get shoppers using that card. The clerks, say, let's see that card. These are actually these are both households as defined by that number. So it's a 12-month snapshot of everything that particular, all the sales linked to that particular card for that family. And likewise in Moab. Now, you'll see later some slides where we actually take all the shoppers in the store and score the store. But here we're scoring an individual household. Good questions. Let's keep them coming. So what do we do and what do we don't do? You can begin to see that there are some potential limitations here. Well, we don't measure dietary intake. Now, that is the standard canonical approach that nutritionists take. And I think this is one of the values that as informaticists we can add to a field like this, because we come in not biased by how I was trained as a nutritionist, in college. We come into it as, where's the data? I got some data. What can I do with it? So we don't look at it like nutritionists. So we get a lot of blowback from people who are sort of traditionalists because they're interested in dietary intake, as cumbersome as it is with those recalls and those food questionnaires. They want to know what individuals eat. Now, they know it's a blunt tool that they're using, but they want to know what the individual eats. We would rather take the approach, we're more interested in the quality of the household food environment for lots of reasons. I mean, it primes kids. We know this from studies. It primes kids for life. It defines what people can eat. So I can't tell you what that diabetic in this family is eating, but I can tell you the foods he or she has access to. And we think that's important. We look at the entire grocery cart, not individual, just like snapshots of selective foods, sentinel foods. We look at the whole thing. And we can do it over any time span. So if we're interested in, so we're doing a study with USDA. We're looking at month blocks because that's what they wanted. They wanted to see if there were trends at the level of a month's worth of shopping, because everyone shops differently. Some people shop, particularly low-income people tend to shop one big shop and then wait until the next set of benefits come. Others shop, like I shop every other day. It's the way I shop. So, but this can be used in any configuration. We're not limited by the time span. We don't focus on individuals, as I said. Okay, so let me help justify then this focus on the household and not the individual. So I would argue that if you did a 24-hour recall, that would capture, in the case of Dave Dorr, it would capture that Big Mac he had last night, and the fruit he had for breakfast, and the pizza he had for lunch today. Right, so it's everything, both in and away from home. But it's a really poor tool, and it's really, really, really hard to get people to do things like write down their foods consistently for any length of time whatsoever. So it's intrinsically not sustainable. So the good thing is, like we said, let's take the thing we can measure with precision, which is shopping data, and see what we can do with that signal. It's an important signal. It's 60 to 70% based on NHANES studies of the calories that Americans eat. So it's a big chunk of what we eat. It's not everything. But we said, let's do that really well, then do individual dietary intake badly. And I would point out that we're doing work with USDA. They don't give benefits to individuals. They give benefits to households. They give benefits to a mother who's got 3 kids. So that's where they're trying to affect change, which is one reason we're interested in affecting change there too. And we don't. There's a product out of Harvard, of course, called NuVal, completely black box. No one knows how it works. It assigns scores to individual foods. Can't do anything in terms of aggregating. We decided to stick with just USDA. I mean, it's not a perfect institution because it wears 2 hats. It's got to encourage agriculture, which means they're beholden to big ag. But on the other hand, they want to help us eat more healthy, so they're beholden to us. It's kind of weird, but their science is really pretty good. So we're comfortable working with those data. Again, grocery data is the entire market basket, 60%, 70%. Was there a question? Of calories. Time span, and best of all is painless. We're not asking patients to do anything different than what they do. Now, eventually we're going to try to encourage them to do what they're doing in a more healthy way, but they're still doing what they're doing. They've got to shop. So they shop, and we help them shop better. It's unbiased by recall. Now, you could argue that if I knew I was being monitored, my health plan was going to give me a $50 a month bonus for staying on this thing, but Whole Foods is not part of this thing. I'm going to go to Whole Foods and buy my cake there, and that's possible. And the only answer I have is ultimately we'd love to get every grocery retailer in the country participating with us, and then there would be no place to hide except 7-Eleven. And retrospective and prospective, that's really handy, so we can monitor compliance and also look back to see what they like to eat. And it's cheap. This store, we got about 200 million transaction records from our grocery partner. It didn't cost us a penny because they already had it. It didn't cost them a penny. They just gave it to us. So it's very, very cheap to get, and it's scalable because virtually every store in the country uses something like this. So it's got a lot going for it. This kind of data is really pretty handy. So how the hell do we do this? So we started off with a very big data donation, 15 months of grocery transactions, 144,000 households in 4 cities, Seattle, Salt Lake, and that sort of big area there, Atlanta, and Richmond. Richmond was just thrown in because it was there. Unfortunately, our partner does not have a footprint in the Great Lakes region or the Northeast. But they had strong presence in these 4 areas. We knew nothing about the households. We de-identified, and we had very little control of what they gave us. You'll see why that's a problem later. So what does this data look like? So I'm going to tell you how it is that grocery stores organize data and then make the case that there's a really fortuitous coincidence here that we could take advantage of. So this grocery chain, and we think most grocery chains do the same thing because they use the same basic structure from IBM. They break foods into departments. An example would be produce. In this gigantic data set, we had 8 different food departments. There they are: grocery, deli, meat, natural foods, produce, drugs, etc. They break departments into commodities. An example would be berries. There's about 326 of those in our data set. Here's some examples. Or sorted by how many different UPCs, how many different foods there are. We had to take out the wines because they were the top 15. Unlike, it's not the case in Salt Lake City for maybe obvious reasons. They don't sell wine in the stores, but they do everywhere else. And so in Seattle and Atlanta, the wines were the most popular, so we had to take them out to get some real food in that list. Passover products, how about that? They're on the top. Value-added poultry. Then they break commodities into sub-commodities, for example, blueberries. There's almost 2,000 of these sub-commodities. Here are the top 13, again, ranked by UPCs, Mexican soft tortillas and wraps. I mean, it's, it gives you an example of the kind of foods there. And then finally, you get the actual food itself, which has a UPC or a PLU code like bananas, 4011. That's the code for some blueberry. And there's about 92,000 in this data set of distinct foods. Okay, what do you think is the #1 food that came out of 15 months of sales, Seattle, Salt Lake, Atlanta, and Richmond for a 15-month period? What do you think? No, water. We didn't count water. A lot of sales. Bread, coffee, milk. The #1 was bananas by a factor of 2. The heartening thing about this list, this is the top 13 or so. These are all pretty good foods, right? There's no junk in there. I mean, there's low-fat yogurt, there's limes, there's avocados, strawberries, eggs. That's pretty encouraging, I think. This is based on transactions. This is based on, so if you bought 1 banana, that would be 1 banana. If you bought 5 bananas and put them on the scale and typed in 4011, or the clerk did, that's 1 sale. So this is transactions that include bananas. And avocados right behind there. No. So the question was, are these foods that are only available to people who there's some foods you can buy with food stamps and some foods you can't, and no, this is all the foods that are in this universe of the 140,000 households. And again, it was much easier for them just to give us everything from these districts as opposed to trying to do a query. We were delighted. Oh, sure, give us all your data. No problem with that. So just to get, I won't dwell on this too long. This is what the data actually looks like. We get a bunch of info on the item itself, like its code. It's the things I just talked about, right? The department, the commodity, the subcommodity. This descriptor. This thing is the universal UPC code. It's called a G10, and then a base thing, and then this descriptor, and then we added this, is this a food or not? We had probably 400,000 different kinds of things that people were buying at these stores, only about a quarter of which were actually foods. They gave us information about the transaction, like which household it was, the time, the date, all the usual stuff, and really importantly, they don't tell us, like if it was a loaf of bread or a package of Cheerios, they don't tell us the size of that box, or at least they didn't very consistently. But they did tell us how much it cost. And you can do a lot with that cost figure, it turns out, as I'll show you later. And then they gave us information about the store, including the longitude and latitude, the geocodes for the store. And from that, we mapped that over to census tract information. And there you have all kinds of data about the environment around the store. So just about any socioeconomic variable you can imagine that the Census Bureau tracks can then be tied not to the household, but to the store. Now, as we go forward with consented families who are giving us their data, we will have their geocode, we hope, and then we can do more precise studies about the environment around those households. But at least we know a lot about the environment around the store. So what do we do? So remember we talked about the food plans and the HEI. To make the HEI model work, we actually map from UPCs over to something called the What We Eat in America food categories. I know this is just fascinating. I love this stuff, but I know it's kind of boring. So there's 150 of those, and we had to add 12 more because when they came up with, so this is the way that they categorize foods for NHANES. This is what that's all about, these WIA codes. And for some reason, back in the beginning, they didn't think to break up whole grains from refined grains, but now we have to do that. So we created our own pseudocodes. So there's 162 of these categories and 29 in the food plans. So then the goal is to map all these UPCs over there. And we lucked out because it turns out that the way grocery stores conceptualize food is very similar in a lot of cases to the way nutritionists conceptualize food. I mean, a banana is a fruit, and fruits are in produce. And you can exploit this homology, and in fact, we could map at the level of the subcoms. Remember, there's departments, commodities, subcommodities. We discovered, one of my graduate students discovered, you could map about 90% of the subcommodities directly to these two groups, WEA categories and food plan categories, without doing any manual review. And I'll show you an example. The other 10% we had to map by hand, but that's a lot easier to map 10,000 than to map 100,000. And because codes change, for example, a decade ago, you would have been hard-pressed to find Greek yogurt in the store. Now it's everywhere. Energy drinks were relatively obscure 10, 15 years ago. Now they're ubiquitous. So UPCs come and go, foods come and go. So we want something that's sustainable. And we think that in the future, as we add more stores and add more UPCs, we can still exploit this lucky, very lucky homology between grocery store organization of food and nutritionists. I'm just going to throw this out here for anybody who's really into food. So USDA also has this thing called the FNDDS, which is an acronym for something, Food and Nutrition Database for Dietary Studies, I think. And there's about 8,000 foods in that. If you go into your computer and type into Google how many calories in an apple, Google's looking here. A lot of the base codes, base foods in MyFitnessPal start here. Almost as we began to look at apps and look at the kind of data they came up with, we could tell because of the numbers they got that they're starting with this freely accessible open database called FNDDS. And what's nice about it, they provide the crosswalk directly to these categories. And they have, it's kind of hard to see, but everything in red up there, these are macro and micronutrients for every 100 grams of these 8,000 foods. So it's really handy if you want to get into really, if you're trying to like emulate the DASH diet, for example, where you're really concerned about sodium, this can tell you a whole lot about the food. So we're interested ultimately in mapping from here to here, but that's proven to be harder than we thought. We haven't solved that problem yet. But we think it's worth doing in the long run. That's just sort of a footnote. So once we've mapped all those UPCs down here, then we can generate these scores from our two models. Give you an example about this homology. So in the case of blueberries, that's actually a subcommodity in our grocer. And I showed 3 examples here. There's a lot more down here, frozen, different. I mean, I don't know why they choose different codes, but there's lots of different fruit codes. So we don't have to worry about any of this detail because we can map it directly here to either that WEA category or that food plan category. And then if they add more blueberries, it doesn't matter. You get another grocery store and they have different codes, but they belong to blueberries, we've already got it mapped. So it has a built-in, we think, sustainable future, this mapping approach. Aaron.
Does it affect if, you know, how it's prepared? Like you could buy peaches or you could buy canned peaches and heavy syrup, and how does it handle that?
So canned peaches would crop up in a different subcommodity, in a different commodity. I don't know off the top of my head where they would be. But you're right, Aaron, nutritionists consider, even though the people in this room might not consider canned peach to be as good as a regular peach or canned corn to be as good as fresh corn, for people on a budget, that's actually it's an important economic distinction, but it's not an important nutrition distinction, at least according to dietitians. So they would love you to eat fresh if you could, but if you can't afford to do that, then it's better to eat canned corn than caramel potato chips. Exactly. So they would be in a different commodity, subcommodity. So I won't dwell too much on this. When USDA first created the food plan, so again, these are oriented by budget, like are you on food stamps, low, middle, high, and they're telling you essentially how many pounds of something to buy a week. And if you just bought all these pounds of stuff for the 29 different categories, and here's like 10 of them, you have everything you need to have a healthy diet. But then that would have been great, but we didn't get, if you might recall, we didn't get the amount, the actual, like how many ounces of Cheerios or pounds of potatoes did somebody buy. But we did get the price, and luckily USDA has exactly the same thing, only broken out by how much percent of your food budget should you be spending on these 29 food categories. And because we have the spend, we can calculate how close they're conforming to these food plan tables because we have the actual amount that people spend. The HEI model estimator, it's a little trickier. So it was designed by one of our postdocs who came out of computer science. She was a numerical modeler. We took a lot of the data that was collected and vetted for the NHANES study I mentioned before. We took 20,000 households worth and essentially looked at if they were buying, just based on counts, this much in this WIA category and this much in this WIA category, what was their overall score for whole fruits or whatever. And because that was big enough, and this was the hypothesis, could we just go directly from counting up how many hits we had in these WIA categories, and then seeing if there was a relationship between that count and the actual HEI scores, which is what that thing does, we can get an estimate, and it turned out to be pretty good. We validated it, and here's the results. For some reason, she decided she wanted to do Chrome box alpha. It was not a good choice. So here's the Pearson's correlation. So you see we do pretty good. So this is measuring our model versus the actual. So in NHANES, there's actually a calculator because they have the nutritionist, dietitian figuring out exactly how much people are eating. If you have that, then you can calculate the score. This is away from home, but we're interested really in foods at home. So those correlations are pretty good. I mean, they're really strong in here. Pretty good, pretty good. And of course, they collapse here. And this gets to your question from before for this particular model. So the ones where we do badly, refined grains and whole grains were bad because we discovered we had an error in our map. And we have fixed that, but not before this was published. But this thing, the fatty acid ratio, which is trying to get at how much saturated fat you're eating compared to all the fat you're eating, sodium and empty calories, because we don't have amounts, we can't really we cannot extract these nutrient-based measures. We just can't do it very well. So we're really good at the things that people should be eating. It's harder for us to get at how badly people are eating with these nutrient-based components. So we're still working on how to, trying to find a way to work around that. Yeah. Well, so the question was, how do we even come up with even a bad estimate for sodium because we're not actually measuring sodium? And let me just, if you will bear with me, run back to this. Sorry, guys. I think it's a really good question.
Don't count added salt?
Well, so the food at home, I don't know. That's a good question. I'll tell you what. I want to get back to one image, but I'm going to have a hard time. I don't want to waste too much time. So that's a good question. I don't know about added salt. So the way we get around this is because we're counting up the number of hits and how many times people bought food in the grocery data or consumed food in NHANES, we know how the people in NHANES, how their sodium, their added sugar, all that stuff distributed across these categories. And so although that tends to work well with things that you can count, like fruits and vegetables, it turns out that using the distributions that were implicit in the NHANES data just didn't do a very good job. And I don't think we're ever going to do a very good job with those. Sorry. But it turns out that the 2015 guidelines have kind of de-emphasized sodium. They've at least raised this is probably heresy to a hypertension doctor, but it's not as critical. But we really want to get at the added sugars, and that's our next major goal because we know that's going to become important. And then someday, I just walked you through all this. This is what we do. We'd like someday then to add like the Mediterranean diet. There's a special modified Mediterranean diet for Americans that Harvard put together. I'm not so sure about DASH, but anything that we can map into these USDA databases, we can calculate, because we've already figured out how to go from the grocery to the USDA. So basically now it's a problem as we want to add new kinds of metrics, figuring out how to map those onto USDA, and because we have the underlying architecture for the grocery stuff. Okay, we're doing a study with USDA, a little tiny study in Utah and a much bigger one in 5 states where we're looking at, this may surprise you, the government gives a lot of money to USDA to give people food stamps, now called SNAP benefits, and the USDA doesn't have any way really to measure how well people are doing on food stamps. So they offer nutrition courses, something called SNAP Ed and FNEP courses, to help educate people about nutrition and diet and exercise. But they don't have any way to evaluate the courses themselves. They don't know if people are actually learning from their courses. So we're, and I think it's a good thing that we're helping people with SNAP benefits. I think it's kind of alarming that we don't know if education interventions are actually working. So USDA gave us a grant to use Walmart to figure that out. So we're going to be looking at recruiting families from these 5 states who are participants in SNAPs, and there's a control arm and the whole works, looking at what they bought 12 months before the classes, and then 12 months after the classes to see if there's a change. Hopefully we'll detect a positive uptick in overall quality in certain areas, and we'll be able to say if that persists, right, if it lasts over time. And if it doesn't, then USDA knows maybe there's something they can do to fix those courses or to improve how they help people on food stamps eat better. The kinds of applications that we envision in the clinical world, we see, we're not here yet. Everything you've seen is stuff we've done. Now here's stuff that we'd like to do. We'd like to create some kind of visual, graphical indicator, and if anybody here is really a whiz-bang, a graphical display of numeric data, we'd love to talk. To give people an idea, patients, how they're doing, and maybe if they're getting rewards, how their rewards are doing. Families like yours got 15 points. Why don't you get, whatever behavioral economical tricks we can use. Could be a smartphone. Even in our low-income population, the vast majority of people have a smartphone device. You guys use Epic, so maybe it's something we could stick into my chart. Still don't know the best way of doing that yet. We also see a set of apps for clinicians. We'd like to make nutrition data, which is now completely absent from the EHR, first-class data citizen. So you can imagine it would be useful just to see it in the context of things like blood sugar and sodium and whatnot. But we'd really like to use it, we think, to get people talking, get clinicians and patients talking about food and saying, gee, you guys did great on your total foods last year, but you're still eating a lot of added sugar. Let's work on that, and then next time you see that person, or maybe my chart can ping them or whatever. I mean, the idea is just to get it in there and let's see how clinicians and patients actually use it. And we haven't really done any work in figuring out, although I have a graduate student now, one of her PhD aims is to do a user-centered design study with clinicians in the pediatrics department to figure out what it is. And this is really tricky. I mean, it's one thing to ask clinicians, how would you like to see hemoglobin A1C for a year displayed? They can imagine that. But how do you want to see nutrition or food displayed? They've got no framework. They can't even suggest. So we have to figure out how to enlist clinicians to help us help them display this data in some way that's actually useful and quickly comprehensible, just like a flow chart or something is now in Epic, and it's an interesting challenge. Illustration purposes only. I mean, you can imagine some kind of app would be nice. Then a couple of, I'm almost done, just a couple of kind of fun facts about HEI. So we measured the Healthy Eating Index using the HEI Model estimator. This is the Salt Lake Valley. That big blue thing is the second saltiest body of water on Earth, the Great Salt Lake. There's a mountain range here, and these are stores. The bigger a dot is, the more households shop there, and the greener it is, the better the overall score. And you can see there's this kind of pattern. When we move west, the scores get paler and yellower, and that pretty much maps to the income distribution in the valley. It's as you go west, literally west of the tracks, the income level drops. And there's a red dot there. It's kind of interesting. Let's zoom in on that red dot. It turns out this grocery chain, so here's the Avenues. We saw that shopper from the Avenue store, upper middle class neighborhood. Pretty big, because it's big and it's pretty green. And then there's this big red dot down here. Turns out that this grocery chain also has a chain of gasoline convenience stores. So they actually do sell food, and they do tie them to the shopper card. And all they sell there is junk food, of course, because it's a convenience store. It's a gas station. And it's nice that that showed up, because if it had been really dark green, we would have been worried. Here's a comparison of overall dairy scores, and HEI has a dairy score. It's an important score. This is, again, a slightly bigger picture of what's going on in Salt Lake just for dairy. So it's kind of hard to see. There's some pale ones here, and then a lot of greenish ones. Seattle, a little less dairy, a lot more fading stuff in the middle here, and a lot more big pink circles. And that's pretty much down by the harbor. And then Atlanta, and then there's this big chunk of lack of dairy. Now, if you were a public health policymaker, we think this kind of information might actually be useful. What's going on in those neighborhoods? Why isn't there more? I mean, when I showed these screens to the guy who runs our University of Utah has his own health insurance plan, the health plans, he said, you know what I'd do is I'd start putting billboards up in these neighborhoods. Got milk or whatever. I mean, anything to just to get dairy on the minds of people. And we think that this might be, a useful use for Walmart technology. Again, it's free. It doesn't cost. It costs us more computation time, but that's cheap to calculate all this stuff. So it's because it's scalable. We think this would be useful across the country. What else do we have here? So when we do our comparisons between our tools and NHANES, they come up good. And we have a gold standard in the NHANES data itself. NHANES can tell us what the HEI is for their respondents. But when it comes to actually measuring households or stores, we don't have a reference standard. There's no gold standard to tell me how my family's doing in the Avenues, because there just isn't any comparable gold standard. So we look around for things like face validity, like that convenience store. But here's another study one of my students did. It's known from the literature that smokers eat more poorly than non-smokers. So we decided to see if we could see that. So we took a random sample of 16,000 households in that big data set and broke them up into two categories: households that never bought any tobacco products of any kind, and those that bought at least one tobacco product at least once in that 15-month period, which is like the most extreme definition you could get. And it turned out that indeed, here higher scores are better, and every time you see an asterisk, that's a significantly higher score, and overall, their overall estimated HEI is almost 10% higher. So we replicated the finding from the literature with our tool, and right now we don't know any better way. We can't really prove that we're getting at the overall quality at the household level because we don't have any other way to measure it as a comparison, but we do studies like this to convince ourselves that we're getting the same results that you would expect from other studies in the literature. And there's the actual distribution. This is the people who don't. Clearly,